Good day, everyone. I'm Dr. Carmen Pugliafito, and I'm delighted to have here today with us on retina synthesis, Dr. John Pollack of Neurotech Pharmaceuticals, where he is the Chief Medical Officer. John, welcome to Retina Synthesis.
Carmen, thanks very much for having me. Pleasure to be here.
So you joined Neurotech Pharmaceuticals about less than a year ago, and but you still have a very active career as a retinal clinician and leader in the field. You were president of the American Society of Retina Specialists. What attracted you to the CMO position?
Yeah, well, if I look back over my career, I think that there are probably several experiences and personal interactions that influenced my path here. Certainly my interest in research, which has spanned benchtop, animal, and clinical research, has been a major part of my career. And it's what's created a really nice balance for me with my medical and surgical practice. And I think that a passion for research is important in this role. But I've also long wanted to know much more about the drug and device development process in far greater detail than we're usually afforded as clinical investigators or even as strategy level clinical consultants, because that level of granularity, as you know, is generally not accessible until you become a company employee. For example, I've long been interested in gaining much greater exposure to industry clinical operations and research and development, which are a natural fit for physicians with an interest in research and innovation. But in addition, I've also had a strong interest in learning about the other medical product development areas that are so critical to success, such as regulatory and manufacturing, and even quality and supply chain. I think another contributing factor for me may be related to what I would describe as a strong entrepreneurial curiosity. Since 2004, I've co-founded 3 physician-focused companies to address unmet needs, 2 of which, Covalent Medical and Vestrum Health, are still ongoing entities. And I think that these experiences also have provided me with valuable on-the-job training in the corporate world, albeit on a relatively small scale. And finally, a few industry friends for whom I have a great deal of respect have been encouraging me to consider dipping a toe into this sort of a role for a while. And that was certainly impactful when this opportunity presented itself. So it was really a combination of all of those experiences that led to my decision to accept the role. And it's been incredibly gratifying and fulfilling to interact with Neurotech's team of very seasoned professionals. And I've learned a tremendous amount from them. So I can say that it's really been a uniformly terrific experience for me.
This is a balancing act, of course. So how much time and effort do you spend on the CMO role?
Well, a lot, but, I did a lot outside of my practice before. So I still practice 5 days a week. I'm in clinic, I'm in surgery. But, prior to assuming this role, I did a fair amount of consulting. I consulted for 10 different companies. I was very involved with the ASRS, and I was very involved with these other companies as well. So what I did was I took all of that time that I was spending on all of these other interests and kind of shifted it. So I dropped all of my other consulting. I had already rotated, off of my responsibilities with ASRS. So I was off the executive committee and eventually off of the board. So that freed up a tremendous amount of time. And my responsibilities with the other companies was greatly diminished. So, as you know very well, there's a lot, you do a lot in the office, but when you have all these other interests, whether it be research or writing papers associated with that or consulting, all of that's done on your off time. So the real balancing act is balancing with family. And fortunately, over the last 25 years, I've figured out a way that seems to work pretty well with my family. And so what I did was really just shift responsibilities from other areas to just being CMO.
So Neurotech has been around for more than a decade, and it has a unique technology platform, the encapsulated cell technology, which is now, I think, a fairly well-proven delivery system. Can you discuss ECT for us?
Yeah, it's one of the things that really attracted me, to this company. One was, what they're looking at, and the other is this platform, which I think is really incredible. So their lead program is this NT501 implant. which produces ciliary neurotrophic factor, or CNTF. It's being studied in a pair of fully enrolled phase 3 studies looking at it as a treatment for macular telangiectasia type 2, commonly referred to as MacTel. And this implant is based on their ECT technology, as you said, the encapsulated cell technology, which is a really interesting, very versatile, customizable platform that consists of human RPE cells that are genetically modified to secrete any of a variety of therapeutic proteins. So this includes growth factors, antibodies, fusion proteins, small peptides. And the RPE cells are encapsulated within a semi-permeable polymer membrane, and the device is then implanted into the vitreous cavity and sutured to the eye wall. In the case of NT501, the RPE cells are modified to produce CNTF. The implant's 6 millimeters in length, about 1 millimeter in diameter. And once it's implanted into the eye, that semi-permeable polymer capsule allows the outward diffusion of the therapeutic proteins in a very controlled and sustained manner, and the inward diffusion of oxygen and nutrients. In addition, it's immune protective because the encapsulating membrane prevents passage of immune cells. So it's a really clever device that can produce a variety of proteins directly into the vitreous cavity in a sustainable manner over many years. So it's attractive for people that need this sustained delivery over the long term.
And it has a good track record because it's been looked at and in AMD, dry AMD, and in retinitis pigmentosa. So these implants have gone into a number of eyes prior to the current studies.
They have, and we're continuing further trials, and we're always interested in safety and efficacy, and that's what we hope to find out.
So tell us a little bit about the pathophysiology of MacTel2 and how CNTF affects that pathophysiology in a favorable way.
So, MacTel primarily affects photoreceptors, but also Mueller cells, RPE cells, and blood vessels. The mechanism of action of CNTF in the MacTel retina is activation of metabolically stressed glial cells to upregulate cell survival pathways and release neurotrophic factors. In the mature retina, Mueller glia are a major source of neurotrophic factors, including CNTF, which supports photoreceptors. So when Mueller glia become metabolically distressed and damaged, it's believed that this injury contributes to photoreceptor cell death. More specifically, it's been demonstrated that Mueller glia express CNTF receptors, and upon binding CNTF, Mueller glia begin to then upregulate the JAK-STAT cell survival pathways. And it's also been shown that inhibition of the CNTF receptor on Mueller glia blocks STAT activation and abolishes neuroprotection. So it's believed that maintenance of Mueller glia by exogenous CNTF may prevent or slow the subsequent collapse of photoreceptors. And this proposed mechanism is further supported by evidence showing that CNTF activated glia are protected against strong metabolic stress. So CNTF's mechanism of action provides a pretty strong basis for evaluation of intravitreal CNTF therapy for the treatment of MacTel. We feel pretty good about that.
Mm-hmm. So can you tell us about the significance of the ellipsoid zone, formerly known as the ISOS junction, in monitoring treatment effects?
Sure. OCT, thanks to you and your colleagues, OCT, has opened up, just a world of information. It used to be that we, had to use visual acuity, but we know that with diseases, whether it's retinitis pigmentosa or MacTel, where there's very, very slow progression, you really need something else besides best corrected visual acuity. Although, progression of MacTel can result in a variety of changes seen on OCT, such as retinal cavitation, we know that the most visually significant change over the long run is ellipsoid zone disruption, because we know that it reflects photoreceptor damage. And with continued photoreceptor damage, there will eventually be a reduction in central vision. And that's why the primary endpoint for the MacTel trials is the rate of change in the ellipsoid zone area at 24 months.
So can you do that in a reliably quantitative way in measuring the ellipsoid zone disruption?
You can, and we have, the Duke Reading Center that does that, and they're very good at it, and that's been validated. So we're pretty confident in their ability to measure that.
So can we talk a little bit about the phase 2 trial, which is complete? How was the trial designed, and what were the findings?
Sure. Well, that was a prospective randomized multi-center trial in 99 eyes. There were 11 sites. The primary endpoint was focused, again, on measuring progression of photoreceptor damage over time. So the primary endpoint was the change in OCT ellipsoid zone disruption at 24 months. And the results of that study were encouraging, with implanted eyes demonstrating 31% less progression of ellipsoid zone disruption compared to the sham-treated eyes. And that was statistically significant. So those results, led to the initiation of the current pair of similarly designed phase 3 studies.
So you did some microperimetry in the phase 2 trial as well, to see if there was a visual function correlate. Can you talk to us about those?
Right. So the microperimetry was paired to the area of ellipsoid zone changes, and that corresponded well to that.
Yeah. What about Snellen visual acuity? Is that something that eventually you're going to get around to looking at?
Well, we look at that, but we know that the Snellen in MacTel, the change in visual acuity doesn't, just like in retinitis pigmentosa, it doesn't show the full dysfunctional problem, and it also is very slowly progressive. So it's very difficult to design a trial that's going to be able to capture that. We know that the anatomy precedes the severity of visual progression, right? And that's why, the retinitis pigmentosa trials are designed, for example, with mobility testing. And the FDA seems to have looked favorably upon using the ellipsoid zone and photoreceptor loss progression sort of as a surrogate for what's going to happen down the road. Because otherwise it's difficult. You'd have to design a much longer trial, and that's challenging to do let's say a 5-year trial over a 24-month trial.
Is this the first clinical trial that uses an OCT finding as its primary endpoint?
I don't know that for certain, but it could be. But I don't know that for certain, but it could very well be.
Yeah. In the geographic atrophy trials, they're really looking at areas plotted by autofluorescence. But
right, but it's a similar premise as well, though, not using visual acuity. Yeah, very similar.
So tell us about the phase 3 trial, which are now fully enrolled, correct?
Correct. So fully enrolled, prospective, randomized, sham-controlled trial, 212 patients at 47 sites. It's designed, similarly to the phase 2 study, again, with the primary outcome of the rate of change in the ellipsoid zone disruption at 24 months. And we anticipate study completion in Q4 of 2020, and we hope to submit a BLA filing shortly thereafter. So we're excited about that.
I think you misspoke. You meant 2022.
2022. Yes, I did misspeak. If I said anything other than that.
Yeah. So when 2022? Which quarter?
Q4. It's hard to pinpoint it specifically where, but we're hopeful that in Q4 we'll have last patient, last visit.
So Neurotech has a unique relationship with the Lowy Family Group and the Lowy Medical Research Institute. It's really unique in the world of corporate retina. Can you describe that relationship and how it works and why it's been beneficial?
Sure. Well, they're a tremendous family, and they have, in 2010, they decided they wanted to focus some of their resources and attention when trying to find a treatment for MacTel. And so they were able to start the Lowy Medical Research Institute, which is headed by Marty Friedlander. Before that, they pulled together the world's experts in medical retina, specifically those with expertise on MacTel. And they pulled together a board of advisors from around the world to help them research this and eventually start this institute and support the institute with research. They are very laser focused on trying to find a therapy for this. They're very committed to it. And so Neurotech has an interesting relationship, with the Lowy family group and with LMRI, the Lowy Medical Research Institute. And it's a wonderful relationship, all with a common goal. And from Neurotech's perspective, it's very nice because you don't have to spend a lot of time looking for additional outside funding because you have a group that's very, very dedicated to finding a therapy for this disease.
Who was the first person to suggest that CNTF would be a good molecule for this disease?
I don't know which of the advisors was the very first one, because there were a group of people that were involved. So I'm not really sure who that one person would have been.
Don't give anybody credit. So CNTF has been out there for a while. Okay. And any other intraocular targets for it?
Yeah, well, we've Neurotech has looked at using CNTF for retinitis pigmentosa and for geographic atrophy well over a decade ago. And those studies did not succeed, but I'm not sure that necessarily means that CNTF won't be beneficial, because I think there are certain aspects to the study design, and there's also changes that can be potentially made to the cell line, for example, to increase production of CNTF. There's changes that can be made to the device to improve output of CNTF. And so, the question is, was it a combination of one, the study design? Because we've learned, retinitis pigmentosa studies don't use vision as a primary endpoint anymore, but that's what was used over a decade ago because we didn't know any better. And so I think that there's actually the potential still to use NT501 for some of these disorders. I think we have to look at it a little bit more detail down the road, but right now we're certainly kind of laser focused on getting MacTel across the finish line first.
And final question, what about using encapsulated cell technology to produce other molecules of interest to the retina community?
Yeah, well, I think that's what's so interesting about this. This device can produce just a variety of proteins, as I said, fusion proteins, antibodies, growth factors, small peptides. So, and we can, change how much protein is produced potentially. So it's open to just, what products are out there. And I think that there's a variety of potential strategic partnerships that could come out of this for delivering proteins to the intraocular space.
Well, John, this has been a great discussion, a great chat, and everybody in the retina community is cheering you on. And we hope that the phase 3 clinical trial will be positive, because it will offer a treatment to patients who've had really no option whatsoever. So, John, thank you for your time on Retina Synthesis.
Well, Carmen, thanks so much for having me here. It's been a real pleasure chatting with you. Thanks.